So our next presentation is the Surgical Methods and Considerations presentation with Dr. Kevin Shah, who's joining us today from Duke Cancer Institute. So please join me in welcoming him.
So thank you for the opportunity to speak on surgical approaches to stomach cancer or gastric cancer today. And I'd also like to thank the Foundation for putting on wonderful symposia like this that really give patients the tools to get through what can be a difficult time and challenging circumstances. So it's truly an honor to be here today. I have no financial disclosures, but I do have a disclaimer, and that is I will show some pictures and videos of stomach surgery, and if anyone's a little bit squeamish about that, you may want to look away. I'll give you fair warning, though. So what I'd like to do today is review briefly the anatomy of the stomach, and with all things in surgery, if you can understand the anatomy, you can understand much better what the decision-making is and how we make and how we approach various operations. And then I'd also like to talk about the various approaches we have, whether it's a standard open incision or laparoscopic or small incision approach. And then finally, what to expect before, during, and after surgery. So as you can see, the stomach is situated right in the middle of the abdomen. It sits sort of in the upper part of the belly, and it's surrounded by a number of important organs. On the patient's right or on your screen left, you see that maroon-colored organ, that's the liver. All the way on the screen right, you'll see a purple organ, that's the spleen. Underneath the stomach is the colon, and right behind it is the pancreas. And you can see how if you have a large tumor that's on the left side of the stomach, it can invade into the spleen or into the pancreas. And you have to be aware of all these relationships before you do an operation. When we break down the stomach, first, before you get to the stomach, you have the esophagus, which carries food through the chest down to the stomach. And where the esophagus meets the stomach, we call that the GE junction, the Gastroesophageal Junction. And that's a little bit of a tricky area in terms of deciding what type of operation you want to do. The very first part of the stomach is called the cardia, and then as it balloons out, you have the fundus, and then the main part of the body, or main part of the stomach, which is the body, followed by the antrum. And all the way at the end, there's a sphincter called the pylorus, and then that leads to the first part of the small intestine. And so depending on where the tumor is located in any one of these parts of the stomach, that determines what type of operation we do. As you can see here, there's all the red lines. Those indicate arteries that supply the stomach. And so you can see that the blood supply to the stomach is quite rich. And as a surgeon, that's advantageous in that we can do many different things to the stomach, and it can tolerate it pretty well because the blood supply is so rich. And there's 4 or 5 major vessels that supply the stomach, and you really only need one of those for the stomach to survive and to have good function afterwards. And so that gives us some flexibility in terms of what we do surgically. Now that you understand some of the basics of the anatomy, you can boil down the surgical decision-making by answering a few very simple questions. Stomach surgery is pretty straightforward, and a lot of it is common sense. And so if you answer these basic questions, you can sort of get the gist as to how we make the decisions we do. So the first and most obvious question is, what is the goal of surgery? So our goal is to remove the entire tumor with some normal tissue around it, some normal stomach around it, so that the edges, what we call the margins, are free from tumor. And then we also want to remove any lymph nodes that might be associated with the cancer and might have had spread to them from the original site. The goal, again, is to remove any cancer in the body. And so if there is spread outside of the stomach, distantly to the liver or the lungs, in most cases we don't do surgery in that case, because when there's one spot that's outside of the stomach, there's a very good chance that there are other spots that we just can't determine. There are select circumstances in which we will do surgery for cancer that's spread outside of the stomach, and it's kind of in similar circumstances to what was discussed earlier about radiating these areas. But again, that's not the norm, and it's for select cases. The second thing we want to do is we want to optimize the function the patient's digestive tract has afterwards. So we want to make sure that if we leave some stomach that it works afterwards, and if we're not leaving any stomach that we do things that can help the patient eat and drink as normally as possible. And then the final thing, which is probably the most important thing, is we want to do this in the safest way that we can. So after you know what the goal is, the next question is what type of tumor you're taking out. So when people talk about stomach cancer, they're usually referring to gastric adenocarcinoma. And when we talk about gastric adenocarcinoma, the surgery that's required is what we call a formal gastrectomy, which is removing entire sections of the stomach, as well as any of the associated lymph nodes, because stomach adenocarcinoma has a tendency to spread little tentacles that you can't see with the naked eye, and so we want to take a large margin on each side of the tumor. And it also has a tendency to spread to the lymph nodes, and so we want to take out all the lymph nodes in that area. There are other types of stomach tumors that exist, neuroendocrine or carcinoid tumors and GIST tumors. These tumors are usually better defined, and they don't have the same tendency in many cases to spread to the lymph nodes. And so in these cases, more limited operation where you just carve out the part of the stomach that's involved and then close it back up might be feasible. So then the next question is, what do you take out? And in this regard, surgery is a lot like real estate. It's about location, location, location. And if you look at the diagram of the stomach and think again about the four major parts of it, if the stomach cancer is in the end part of the stomach, we usually take out the end part of the stomach, which is called a distal gastrectomy. And then we pull up a piece of intestine and sew it to the stomach so that you have a residual pouch that can still serve as a reservoir for food. If the stomach cancer is more towards the top of the stomach, where the esophagus meets the stomach, we usually take out the entire stomach, as you see in image D. The reason for that is we want to, again, make sure that we take enough stomach on either side of the tumor. And the reason why we don't do what's demonstrated in image B as often, though there are some surgeons who do it, is because when we divide the connection between the stomach and the esophagus, we divide the nerves that help stimulate the stomach to move and contract. And so what you're left with is a piece of stomach that doesn't really work very well. And in addition to that, people get very bad reflux when you hook up the bottom part of the stomach to the esophagus. And so for that reason, I don't do this type of operation, and most people don't either. Like I mentioned earlier, when the stomach cancer is right at the junction between the esophagus and the stomach, it can be difficult to figure out whether you have to take out the esophagus or if you have to take out the stomach. So when the tumor is more situated and centrally located in the actual esophagus, those patients get their entire esophagus removed with a little bit of stomach. When it's further down and it's more in the stomach and a little bit in the esophagus, they usually get their entire stomach removed with a little bit of esophagus. And then you hook up a piece of intestine to the esophagus, and people can eat and drink normal food. It's just that they have to drink and eat smaller quantities and much more frequently. The next question is, how much do you take out? And again, this goes back to what we're trying to achieve, which is removing the entire tumor with normal tissue around it. And because gastric adenocarcinoma has a tendency to send out little tentacles of tumor, we like to get at least 2 inches or 5 centimeters on either side of what looks grossly abnormal. The issue with the lymph nodes is one that's a little bit more controversial. In this country, we usually shoot for a total of 15 lymph nodes. And if you look online, you may run into descriptions of what people call D1, D2, and D3 lymphadenectomy. And what that refers to is just the extensiveness of the lymph nodes that you're retrieving. So a D1 lymphadenectomy, which means just collecting the lymph nodes that are right around the stomach, a D2 lymphadenectomy, which goes a bit beyond that and collects the lymph nodes that are along the arteries and veins that supply the liver, the spleen, and that central area around where they take off. And then a D3, which is the most extensive, which takes lymph nodes from very distant locations. And intuitively, it makes sense to take out as many lymph nodes as you can. And the reason why we care about it is because as the tumor gets bigger and as it gets deeper in terms of its invasion into the stomach wall, it has more of a tendency to spread to other locations, particularly the lymph nodes. And so the bigger the tumor is, the more likely it is to have some lymph node involvement. And so intuitively, it makes sense that if you take out all those lymph nodes, that the patients will do better, and there may be an increased cure rate. However, the downside of doing that extended lymph node dissection is that it may be associated with higher complication rates, and it's a much more technically demanding operation to do. The Japanese and the Koreans, who probably do the most stomach surgery in the world for cancer, are pretty staunch advocates for doing this extended lymphadenectomy. In Europe and the United States, that enthusiasm has not been equal to what the Japanese and the Koreans do. And the reason for that is many of the early studies showed that there was a significantly increased risk in doing that extended lymph node dissection, but not the same benefit that was documented in Japan. The critics of these studies point out that, number one, many of the centers that did this didn't have a great deal of experience doing the extended lymph node dissections. And the second thing is that when this was initially described, it included removing part of the pancreas and the spleen as part of the lymph node dissection. And those two things dramatically increase the risk profile of the operation. And so the best known Western study, there's a clinical trial that compared D1, a limited lymph node dissection, to a D2, which was an extended lymph node dissection. The initial results didn't show any survival advantage to the extended lymph node dissection. But what they found when they reviewed all the data 15 years later is that when you take out the patients who had spleen removal and pancreas removal and just had the extended lymph node dissection, those patients actually did better. And their overall survival at 15 years was improved compared to those that had a limited lymph node dissection. And so the take-home point that they had is that a modified D2 lymph node dissection, which means it doesn't include spleen removal or pancreas removal, is safer and confers a better survival advantage. And so I think most people at academic or tertiary care centers now would probably recommend that patients get an extended lymph node dissection. The next question is, how do we take out the tumor? And there are various approaches that we have. The classic approach is a standard open incision, which means making a cut up and down or under the rib cage, and that can be, a foot to 2 feet in length. Versus a minimally invasive approach, which is a series of small incisions, probably the biggest of which would be this, to take out the cancer through. If you asked anyone if you want a 2-foot incision or a 3-inch incision, I think anyone's going to say they want a 3-inch incision. The problem is, you have to pick the right tool for the job. So the same way that you wouldn't hammer in a nail with a wrench, you're not going to take out a really large tumor that's 20 centimeters or 20 inches in size laparoscopically, because you have to make a big incision anyways to take it out. Furthermore, there are advantages of open surgery. You can put your hand in, you can feel things. In some instances, it may be safer because you can get control of blood vessels. However, there are significant advantages to laparoscopic or minimally invasive surgery. And that is, in the short term, there's less pain, quicker recovery. Patients get out of bed sooner, they feel better. And if it's possible and it's safe to do it that way, that's now the preferred way to do it. As long as patients think that, as long as the surgeon thinks that they can do the same cancer operation with the small incisions as they can with the open incision. Now, there are two main flavors of minimally invasive surgery. One is laparoscopy, which uses long, slender instruments that are fixed and rigid, and you look in by blowing up the belly and look in with a camera and do the dissection that way. Versus robotics, which involves using, so this is a picture of laparoscopic surgery. So you can see there's long, rigid instruments, and you're looking in with a camera, the belly's filled up with air, and you do the dissection that way. Robotic surgery, the surgeon is not actually standing at the bedside. The surgeon is standing at a console that controls the robot, which is docked to the patient and controlling all the movements. So the robot isn't actually doing anything differently that the surgeon isn't giving input for. The real advantage is that it can bend in a way that laparoscopic instruments can't, and it sort of mimics the way that your hand and wrist can move. And so that's what the advantage of robotic surgery is. And what it comes down to is there's no real advantage one way or the other for the patient, whether it's robotic or laparoscopic. What it has to do with is what the surgeon's comfort is. And the robot makes suturing in the abdomen easier, particularly for surgeons who are not used to doing advanced laparoscopy. And so that's where the advantage is. So it has more to do with the surgeon than the patient. Both are tools to actually do minimally invasive or small incision surgery. So I'm going to show you a short video. This is a 21-year-old male, so a very young patient who initially presented with bleeding from his stomach. And he had a scope, and that showed an ulcer. They stopped the bleeding. He got better. They gave him an acid blocker to try and heal the ulcer. And he came back 6 weeks later for a repeat scope, and the ulcer had not gone away. And so it was biopsied, and the biopsy came back as consistent with cancer. He went for genetic counseling and genetic screening, which didn't show any abnormalities, and he also had a PET scan that didn't show distant spread. And so we took him to the operating room, and here we have the stomach elevated up, and we're freeing the stomach from the pancreas. And after we free the stomach off the pancreas, we divide it with a stapling device. So this is dividing the duodenum, the first part of the intestine. And after we free that up, we're now beginning the D2 lymphadenectomy, so harvesting all the nodes from the area surrounding the stomach, as well as those that are going along the major blood vessels. The reason why many people are hesitant to do this or not advocates of it is that it is very tedious to do, and you have to very carefully dissect this, all these nodes off major blood vessels, and there is a risk for bleeding if you're not careful. So here, this is dissecting off the nodes from the hepatic artery, and we're using a device that seals small blood vessels. So as we dissect it out, we can take all those small blood vessels, seal them, and then divide them. And as this node comes up, you're going to see the hepatic artery, which is the main liver artery, sitting right underneath the node in a moment. And so it looks like it's just one node right now, the thing that's being elevated to the right of the screen. But once it gets freed up, you're going to see that there's a whole packet of nodes. And so it's easy just to go after that one node and ignore the rest. And that's why these operations, they take longer, and they are more challenging to do. So now you can see as this is divided, the entire hepatic artery is exposed underneath. So you can see the artery here, and then we'll continue taking those lymph nodes off. And you can see the lymph nodes are now extending back behind where it looked like there was just one node, there's a whole packet of nodes. So the next thing after this is you're going to see the main vein that goes to the liver. It's called the portal vein, and we've cleared all the tissue off of that. And it's sitting on the backside right here of the liver artery, the hepatic artery. So that's the portal vein that's freed up of all tissue and all the lymph nodes. And then after this, we go on and take one of the main veins that drain the stomach. This is called the coronary vein or the left gastric vein. And then we control that with clips. You can probably skip ahead a little bit. And then we seal it again. These are the lymph nodes that are going to the spleen. What's that? Yeah. So we'll just skip ahead in the interest of time. So this patient did very well. He left on the second day, and all his margins were negative, and there were no nodes, and 28 examined. So what do you expect with surgery? So the actual operation takes somewhere between 3 to 6 hours, and it depends if you have to remove the entire stomach or if you have to remove just a part of the stomach. There are three main risks that are associated with surgery. There's a risk of infection, there's a risk of bleeding because of all the large blood vessels that are there, and there's a risk of leakage where the stomach is reconnected to the intestine or where the esophagus is connected to the intestine. That risk, when it's connected to the stomach, is lower. It's probably about 5%. When it's connected to the esophagus, it can be as high as 20%. And the hospital stay, things have changed pretty dramatically in the last 5 to 10 years. It used to be in the old days that patients would stay in the hospital for 2 weeks. They would have a tube in their nose for a week. They wouldn't eat or drink anything. They would be on bed rest. Now, patients start eating and drinking pretty soon after surgery, often the night of surgery, and they get up and start walking around pretty quickly after surgery. And so it's shifted from a timeline to really reaching certain milestones. So when you can get up and walk, when your pain is okay, and when you can tolerate liquids, you can go home. There are some issues that people can encounter after surgery. The first is even though the surgery goes totally smoothly and there's no complications, it can take a couple months before you really feel like yourself again. You're tired, your energy isn't the same, and you might feel nauseated, your appetite's not great, and all those things are not unexpected after a stomach operation. Most patients will lose weight. It's not unexpected if you lose 10 to 20 pounds in the first month or so, and over time, many people can gain that back. Part of the difficulty is there's a change in the way that you eat. You can't eat 3 big meals a day because you don't have that big stomach reservoir anymore. And so what you need to do is eat 6 or 7 small meals a day. Really, you're snacking throughout the day, and that can take some time to get used to. Another thing that can happen is because there's not a stomach to serve as a reservoir, the food feels like it goes straight through you. And so if you eat a large quantity, you feel full, you have a lot of cramping. Some people get flushing and dizziness. And their heart starts racing. And so what you need to do is, if you alter the diet for most people, this can be remedied pretty easily. The other thing that can happen is reflux, and then you need certain vitamins that can be absorbed in your stomach, and you need those as supplements. And I don't know if we have some time for some questions. Yeah.
I'm going to come up with a microphone just so our webcast can hear it too. Sorry.
On one of your slides, you said that the Japanese do more surgeries, or they had more experience in it, and I was wondering, why is that?
Yeah, it's because stomach cancer is much more common in Korea and Japan than it is here. So they actually have a screening, the way that we screen for colon cancer, they screen for stomach and stomach cancers. And it's not entirely clear why it's so much more common in Japan and Korea. There are many different theories as to why that might be. Some of them are genetic, some of them are environmental, but it's much more common there. And so That type of operation is very common and routine in Japan and Korea. Where here, if you go to a community surgeon, they may have done one in the last 5 years. So it's not a very common thing here.
I also had one more
Yeah.
question. You said the lymph nodes, when they took out all the lymph nodes, I'm not exactly clear what lymph nodes do, if
Yeah.
they're a filter, or if you need all of them, or if there's any consequences from taking all of them out.
Yeah, that's a great question. So lymph nodes, they are little channels that carry fluid in them, and they serve a number of different roles. In the gut, sometimes they carry certain fats. They also help with your immune system, and so there are no long-term consequences to removing all those lymph nodes. Sometimes you can get leakage of lymph fluid, but in reality, there's no long-term consequences to removing those lymph nodes. They're just part of your body's system of carrying certain types of fluid and the immune system.
So I was going to ask, if this is outside of your expertise a little bit, I know, but I have a lot of patients ask me about cytoreduction and heated intraperitoneal chemo.
Yeah.
So I at least just wanted to include a
Yeah.
snippet about that in case anybody's wondering about that.
Yeah, so I think this is an area of evolution. What Dr. Uronis is referring to is when there's spread of the stomach cancer outside of the stomach, particularly to the lining of the belly wall. For other disease states, we basically strip all the lining of the belly wall and then put chemotherapy directly into the belly to try and treat that. There have been some people who have done it for stomach cancer. The problem is stomach cancer can behave more aggressively than the other types of cancer that it's been done for. There is currently efforts to do a trial to see if that benefits patients with very low volume or oligometastatic disease, as Dr. Blackstone mentioned before. And so if there's low volume of disease outside of the stomach on the lining of the belly wall, that may be an option. It's just not a mainstream one now. In the same way we think about spread to the liver, if there's one spot to the liver and it's been a long interval between when the patient was initially diagnosed and when the spot came about, sometimes we will remove that spot, but that's not the mainstay of surgical treatment.
Yeah, so I would say I think cytoreduction HIPEC is still investigational.
Yeah.
It's definitely not
Correct.
something that would be routine at all. So if that's something you're thinking about, I would go to a center that
Yeah.
specializes in that.
Yeah, most of these things that are a little bit outside of the mainstream really should be done in the context of a clinical trial and not just done as one-off procedures.
So we have time for one more question, which we received online through the webcast. What are the current thoughts on endoscopic resection of a small early-stage tumor?
Yeah, another very good question. And it definitely does serve a role. The issue is in this country, we see very little early gastric cancer. There is some, and for very early stomach cancers that haven't penetrated deep into the stomach wall, that is a reasonable approach. And the reason for that is, one, if it spreads too deep into the stomach wall, there's an increased chance for spread to the lymph nodes. And number two, it's hard endoscopically with a camera in the mouth from the inside to get deep enough to get the entire tumor out. Again, this is something that's more commonly done in East Asia than it is done here, but for early gastric cancers, it is a viable approach.